Welcome to this month's webinar on traumatic brain injury. My name is Monisha Kumar, and I'm a neurointensivist and director of the Neuro-ICU at the Hospital of the University of Pennsylvania in Philadelphia. I am one of the authors on the On Call chapter on TBI, along with Megan Kaler, Chris Morrison, Megan Moyer, and Josh Levine. The purpose of this webinar is to provide complementary material to the On Call chapter on TBI. Over the next 30 minutes, I will review the chapter, including the epidemiology, diagnosis, classification, and management related to TBI, as well as highlight some notable content within the chapter, such as figures and tables. I will also briefly discuss some underlying physiological principles that underpin some TBI treatment strategies. Please refer to the chapter text for all cited references, as they are not included on the slides. Traumatic brain injury is a major health problem worldwide and is a leading cause of death and disability in young adults in developed countries. In developing countries, the incidence of TBI is steadily increasing. It's important to note that the term traumatic brain injury encompasses a heterogeneous group of disorders, each with its own presentation, pathophysiology, natural history, treatment, and prognosis. But because it's heterogeneous, categorization proves extremely important. TBI may be categorized by mechanism of injury, clinical severity, radiologic appearance, pathology, and distribution, either focal or diffuse. A major pathophysiological concept that has come to the fore in recent years is that brain damage not only results from the initial physical injury or primary injury, but also continues to occur from subsequent metabolic derangements, and this is known as secondary injury. Mitigation of secondary injury has become the central goal of pre-hospital and intensive care management. Authoritative guidelines for the management of TBI exist from the Brain Trauma Foundation, the American College of Surgeons, the Congress of Neurological Surgeons, and the Neurocritical Care Society. Although adherence to guidelines has been associated with a reduced mortality and improved 6-month outcomes, it should be noted that while these guidelines serve as the foundation for modern intensive care management, randomized control studies published since the release of these guidelines also inform care. According to the CDC, TBI contributes to nearly 1/3 of all injury-related deaths, and over 5 million U.S. residents live with TBI-related disabilities. The societal cost of TBI is tremendous. In 2013, there were approximately 2.8 million TBI-related healthcare encounters in the United States. These consisted of 2.5 million ED visits, 282,000 hospitalizations, and 56,000 deaths. These encounters vary by age, with the highest rates in the elderly, followed by children under the age of 4 and people between the ages of 15 and 24. Overall, men have a higher age-adjusted rate of TBI compared to women. In the civilian population, the leading cause of TBI is falls, with blunt impact and motor vehicle crashes as second and third. Falls preferentially account for TBI at extremes of age, namely less than 4 and greater than 65. Blunt impact and motor vehicle collisions are the predominant cause of TBI in teens and young adults. Let us digress and speak briefly about cerebral physiology and goals for resuscitation. In a general sense, for TBI patients, the immediate goal of resuscitation is to restore and maintain adequate tissue metabolism by ensuring sufficient delivery of fuel, which is typically oxygen and glucose, to meet cellular metabolic demands. Cerebral blood flow approximates fuel delivery, but it's difficult to measure. Intracranial pressure, which is easier to measure, and cerebral perfusion pressure, which is calculated as the mean arterial pressure minus the ICP, are thus used as surrogates for cerebral blood flow. If modeled as a flow through a rigid tube, then according to Prehospital law, CBF is proportional to CPP and proportional to the radius of the vessel raised to the 4th power, and inversely proportional to blood viscosity. CBF is maintained constant across a wide range of cerebral perfusion pressures through modulation of vascular diameter. This is called pressure autoregulation. When pressure autoregulation is intact, the primary determinant of cerebral blood flow is vessel radius, and CPP has little impact, as is depicted in Figure A. Conversely, When pressure autoregulation is impaired, changes in CPP can significantly impact CBF, and blood flow becomes pressure passive. This is figure B. In patients with TBI, pressure autoregulation may be preserved, partially intact, or absent, and there's often considerable regional heterogeneity of pressure autoregulation status within the brain. The use of ICP and CPP as surrogates for CBF therefore assumes that pressure autoregulation is disturbed. These surrogates, ICP and CPP, are at best estimates and may not reflect accurate global or regional brain perfusion. ICP is defined by the Monro-Kelly hypothesis, which states that the ICP is the sum of the pressures exerted by the contents of the intracranial vault, namely brain tissue, cerebrospinal fluid, and blood. The cranial compartment can accommodate roughly 150 cc's of additional volume before ICP rises. This represents compensatory mechanisms. As intracranial volume is added, low pressure veins collapse and cerebral blood volume decreases. As further volume is added, there is egress of spinal fluid from the cranial subarachnoid space into the spinal subarachnoid space. But once these reductions in CBF and cerebral blood volumes are maximized, the addition of further volume leads to a sharp rise in ICP. Cerebral compliance is defined as the change in cerebral volume per unit change in pressure. Because of the aforementioned compensatory mechanisms, the cerebral compliance curve is not linear, but rather it's logarithmic. TBI patients with intracranial hypertension may operate on the steep portion of the compliance curve, where small changes in intracranial volume are associated with large changes in ICP. The pathophysiology and clinical presentation of TBI are largely dictated by its broad mechanistic category. Blunt trauma, penetrating trauma, and blast injury each have attendant pathophysiological consequences and clinical features that partially overlap. Penetrating TBI is far less common than blunt head injury, but is associated with worse prognosis. In 2013, intentional self-harm was the leading cause of death from TBI, and the vast majority of these deaths were due to firearms. While rare in the civilian population, blast TBI is observed primarily in soldiers exposed to improvised explosive devices, or IEDs. Within each mechanistic category, pathophysiology may be subdivided into primary and secondary injury. In blunt TBI, primary injury is caused by impact of the head with a blunt object and rapid acceleration-deceleration forces. This primary injury results in mechanical forces that cause tissue distortion, compression, shearing, and swelling. Manifestation of these forces include cerebral contusions, extraaxial hematomas, and diffuse axonal injury. Contusions, the most commonly observed mass lesion in patients with TBI, are regions of hemorrhagic necrosis due to acceleration-deceleration. These contusions may be ipsilateral to the site of impact, or coup injuries, or contralateral to the site of impact, contracoup. This image is a non-contrast axial CT demonstrating right greater than left frontal lobe contusions with hemorrhage. Contusions are observed particularly in the gyral crests of the orbitofrontal and anterior temporal regions due to friction against the rough inner table of the skull. While contusions may appear as multifocal areas of patchy hemorrhage, these hemorrhages may coalesce into larger parenchymal hematomas. Expansion of contusions is common and is associated with clinical deterioration. Up to 65% of patients have some amount of contusion growth, while 45% have significant growth defined as greater than 30% increase in volume. This image is a non-contrast CT demonstrating a left convexity epidural hematoma. Note the lentiform shape. Epidurals are observed in 2% of patients. They typically occur in the context of a skull fracture crossing the groove of the middle meningeal artery. While laceration of the middle meningeal artery is most commonly responsible for an epidural, epidurals can also result from injury to the middle meningeal veins, the diploid veins, and the venous sinuses. Epidural hematomas do not cross skull suture lines. The classical clinical description of an epidural is the lucid interval, in which patients are initially conscious, then unconscious, and wake up without obvious deficit, but subsequently deteriorate. The classic description of epidural hematomas is the lucid interval, in which the patient is initially unconscious, wakes up without an obvious deficit, and then subsequently deteriorates. Most patients with epidurals are comatose on admission or immediately prior to surgery. This image demonstrates a massive left convexity subdural hematoma with mass effect, effacement on the lateral ventricle, and right and left to right midline shift. Subdurals are present in up to a third of patients with severe TBI. They typically occur because of rupture to bridging veins and are often associated with severe underlying brain injury and a high mortality. They usually occur over the cerebral convexities, but may also occur along the tentorium or falx cerebri. Subdural hematomas are classically crescent-shaped and do cross skull suture lines. A minority of patients have a lucid interval, and there is no associated skull fracture. Traumatic subarachnoid hemorrhage results from tearing of small PL vessels. Blood is typically located over the cerebral convexities and is often confined to a few sulci or fissures. However, traumatic subarachnoid hemorrhage may distribute diffusely over the cortical surface into the basal cisterns or into the ventricles. But it should be noted that isolated intraventricular hemorrhage due to trauma is unusual. Diffuse axonal injury is commonly observed after rapid acceleration and deceleration of the head, typically in the lateral plane. DAI is a form of both primary and secondary injury. There may be immediate mechanical damage or primary injury to structural elements of axons, such as microtubules, that's evident at the time of trauma. However, axonal swelling and ultimate axotomy, or transection of the axon, is the consequence of cellular cascades that are initiated by trauma and is called secondary injury. This form of secondary injury may occur in severe, moderate, or even mild TBI. Brain regions that are commonly affected include the junction between the cortex and white matter structures close to the midline, including the corpus callosum and internal capsule, as well as other white matter structures like the corona radiata, the brainstem, cerebellum. Diffuse axonal injury is rarely fatal, but it is associated with increased odds of poor functional recovery. Classically, patients with DAI have a depressed level of arousal that is out of proportion to the burden of injury observed on CT scan. CT imaging may reveal small punctate foci of hemorrhage, but is frequently unremarkable. Therefore, MRI is often obtained and may display abnormalities on diffusion-weighted gradient echo and diffusion tensor imaging. Vascular injuries occur in the context of blunt TBI and may include arterial dissection, arterial pseudoaneurysms, arteriovenous fistulae, or vessel perforation. In centers that routinely screen patients, the incidence is reported as high as 1 to 3%, especially in those with an elevated injury severity score. However, the actual incidence of blunt cerebrovascular injury is unknown and is likely underreported. Although contusions, epidurals, subdurals, and subarachnoid hemorrhage are all commonly observed in penetrating TBI, the hallmark of penetrating TBI is the cerebral laceration. As a missile or bullet penetrates the brain, it tears the parenchyma, leaving a track with necrosis and hemorrhage. This is called laceration. In the wake of that projectile, tissue is compressed, collapses, but then re-expands in repeating wave-like patterns that further injure tissue. The nature of primary injury in penetrating TBI is largely dictated by ballistic and material properties of the bullet, as well as the properties of secondary projectiles, like bullet fragments or bone fragments. The degree of tissue injury is partially dependent on kinetic energy transferred from the missile to the tissue. Since kinetic injury is 1/2 of the mass times the square of the velocity, higher velocity projectiles tend to cause more tissue injury than lower velocity projectiles. Projectile paths that cross the hemispheres, violate the ventricles, or that involve the brainstem have a poor prognosis and are most frequently fatal. Compared to penetrating TBI from a missile, non-missile penetrating TBI, as in stab wounds from knives or nail guns, has a lower mortality rate, and the injury is more restricted to the path of the laceration. Penetrating TBI is frequently accompanied by CSF leak and cerebrovascular injury, which occurs more commonly with penetrating TBI than with blunt TBI. Cerebral blast injury occurs when acoustic, electromagnetic, light, and thermal energy that emanates from an explosion are transferred to the brain directly through the cranium and indirectly through oscillating pressures in fluid-containing structures such as blood vessels. The diffuse axonal injury of blast TBI occurs in a dose-dependent fashion that differs from the DAI observed from closed head injury, in that malignant cerebral edema occurs rapidly, and cerebral vasospasm is more common and may last longer. Patients with blast TBI frequently have concomitant injury to the ocular and auditory as well as vestibular systems due to fluid-filled components of these structures. Secondary injury involves organ-level abnormalities and cellular and molecular cascades that promote cell death and exacerbate cerebral edema and ischemia. While these processes begin immediately, they often last for hours to days. Studies of secondary injury in experimental models and in humans with blunt TBI demonstrate that cerebral ischemia, intracranial hypertension, systemic hypotension, hypoxia, fever, hypocapnia, and hypoglycemia all independently worsen survival after blunt TBI. Importantly, coagulation derangements occur in 1/3 of patients with severe TBI and may exacerbate ischemic brain injury through microvascular thrombosis and embolism. The diagnosis of TBI is often self-evident. When the history is unavailable, the diagnosis is typically made by physical exam in conjunction with neuroimaging studies. Physical exams should include an assessment for trauma, including superficial abrasions, lacerations, soft tissue swelling of the head, as well as entry and exit wounds for penetrating TBI. Signs of basilar skull fracture may be present, including retroauricular ecchymoses or battle sign, periorbital ecchymoses or raccoon sign, hemotympanum, and CSF otorrhea and rhinorrhea. The Glasgow Coma Score, GCS, should be used to assess, categorize, and to communicate the severity of injury. Generally, severe TBI is defined by a GCS of 3 to 8, moderate TBI by a GCS of 9 to 12, and mild TBI by a GCS of 13 to 15, although now there's new taxonomy including complicated mild with a GCS of 15 but positive CAT scan. The GCS is easily determined, has good inter-rater reliability, clear prognostic value, and is widely used, but it does have limitations, particularly for patients who are intubated or aphasic. These limitations have been addressed by other scales, such as the full outline of unresponsiveness or force score. However, use of the GCS is presently more widely adopted. Neuroimaging studies may assist in diagnosing the particular types of primary injury present. We have already reviewed the typical radiological characteristics of primary injury, but imaging should be performed in all patients where there is any alteration in consciousness, focal neurologic signs, seizure, penetrating injury, signs of depressed or basilar skull fracture, confusion, or agitation. CT is the initial imaging modality of choice because it's widely available, may be performed rapidly, and is highly sensitive for acute blood and can guide surgical intervention. MRI is more sensitive than CT for soft tissue pathology, but is less available and may pose logistical challenges and patient safety issues related to transport and monitoring. Neuroimaging studies may also be used to categorize TBI, particularly for research purposes. Two classification schemes, the Marshall and Rotterdam, are most commonly used. Treatment of TBI may be divided by phases of care: pre-hospital, emergency department, ICU, and post-acute. The noted recommendations are based on the Brain Trauma Foundation, the American College of Surgeons, and the Neurocritical Care Society, and pertain to patients with severe blunt TBI. There are separate guidelines for those under the age of 18, penetrating TBI, and combat-related head trauma. Regarding pre-hospital treatment, it should be noted that minimization of secondary cerebral injury begins in the pre-hospital phase, where the primary goals of therapy are avoidance and treatment of hypotension and hypoxia, both of which are associated with worse clinical outcomes. In the ED, initial treatment should proceed according to ATLS, Advanced Trauma Life Support, including maintenance of adequate oxygenation and blood pressure. Recent guidelines for in-hospital management have raised the lower systolic blood pressure threshold in an age-dependent way, SBP greater than 100 for patients who are 50 to 69, and greater than 110 for patients who are 15 to 49 or greater than 70 years old. Imaging in the ED may be guided by a new FDA-approved assay in mild TBI. Ubiquitin carboxy-terminal hydrolase L1, or UCHL1, and glial fibrillary acidic protein, GFAP, are biomarkers that rapidly appear in the blood after TBI. If the combination biomarkers are elevated, neuroimaging may be indicated. This test, though, may obviate imaging for some patients and reduce unnecessary exposure to radiation as well as healthcare costs. Patients with TBI often require immediate surgical management. Table 3 in the chapter summarizes recommendations for surgical interventions for mass lesions. We will discuss secondary craniotomy for ICP control in a few slides. Medical management of the patient with severe TBI typically occurs in an intensive care unit where the focus is on minimization of secondary cerebral injury and on prevention of systemic complications. We have discussed avoidance of hypotension and hypoxia, and over the last few minutes of the talk, we will discuss ICP, CPP, and other multimodal neuromonitors and general critical care strategies. The indications for invasive ICP monitoring are still somewhat unclear. The Brain Trauma Foundation recommends, based on low-quality evidence, using data from ICP monitoring to manage patients with severe TBI, defined as a GCS less than 8, in order to reduce in-hospital and 2-week mortality. The American College of Surgeons recommendations are somewhat different. They recommend consideration of an ICP in patients who have either a GCS less than 8 and evidence of structural brain injury, or patients with a GCS greater than 8 who have structural injury on CT and who are at high risk for progression, or patients who require urgent surgery for extracranial injuries who need mechanical ventilation due to extracranial injuries, or who have worsening pathology on serial imaging or clinical deterioration. It should be noted that in 2012, the multi-center randomized trial, BEST TRIP, of 324 patients with TBI conducted in Ecuador and Bolivia found that therapy targeted to maintain the ICP less than 20 with the use of an invasive monitor was not superior to therapy based on clinical examination and CT findings. Whether these results are generalizable to TBI populations in developed countries is unclear. Typically, ICP is monitored with an external ventricular drain or an intraparenchymal probe. EVDs are considered the gold standard. Unlike intraparenchymal monitors, EVDs are not associated with measurement drift and may be used for ICP measurement and therapeutic CSF diversion. However, EVDs may be technically more difficult to place at the bedside than intraparenchymal probes, especially when the ventricular system is compressed or displaced from injury. Furthermore, EVDs are associated with a higher rate of bleeding and infection than intraparenchymal ICP monitors. Older methods that measure pressure in the subarachnoid, epidural, or subdural spaces are not recommended due to their lesser accuracy. The optimal threshold above which ICP should be treated is unclear. While it's common to place and maintain ICP less than 20, the Brain Trauma Foundation, based on low-quality evidence, now recommends initiating treatment when ICP exceeds 22 millimeters of mercury. This threshold is based on a retrospective study of 459 patients in which statistical analysis was used to define a threshold that best discriminated survivors from non-survivors and between those with good functional outcomes and those with poor functional outcomes. The American College of Surgeons recommends using 20 millimeters of mercury as an alert threshold and instituting therapy for ICP between 20 and 25 millimeters of mercury. While intracranial hypertension is associated with increased mortality and worse outcome, it's not clear that lowering ICP improves outcome. There have been studies of numerous maneuvers that successfully reduce ICP, such as craniectomy, hypothermia, and pharmacologic coma, but none have been shown to improve outcome. Nonetheless, control of ICP remains, at present, the cornerstone of TBI management. When ICP remains elevated, a series of tiered therapies are employed. With the exception of induced hypothermia, as noted in Tier 3 of the ENLS algorithm, the same concepts apply to treatment of intracranial hypertension or herniation resulting from severe TBI as from other etiologies of acute brain injury. Initial Tier 1 therapeutic measures in the ICU are largely preventative and include head-of-bed elevation, maintenance of head and neck in a neutral position, prevention of hypercarbia, adequate treatment of pain, agitation, fever, and seizures. Tier 1 measures include CSF drainage through a ventriculostomy. The optimal method of drainage, continuous versus intermittent, has not been definitively established. There are EVDs that now permit both continuous CSF drainage and continuous ICP monitoring. If CSF diversion is insufficient or unsuccessful, or if an EVD is not present, then osmotic agents, typically mannitol or hypertonic saline, may be administered. While both may be equally effective, there are insufficient data at this time to suggest superiority of one agent over another, and data on mortality and functional outcome are lacking. Please see the available PONS presentation, Osmotic Therapy for Elevated Intracranial Pressure, for an in-depth review of this topic. And also look out for the upcoming Neurocritical Care guideline on cerebral edema management that may further address these topics. Hyperventilation. Hyperventilation results in blood and CSF alkalosis, which leads to cerebral vasoconstriction, reduced cerebral blood volume, and therefore a lower ICP. Sustained hyperventilation can worsen cerebral ischemia and is therefore not recommended as routine therapy. However, in emergency situations, such as herniation, hyperventilation may be used as a bridge to more definitive therapy, like getting a patient to the operating room. Some people suggest that jugular bulb oximetry may allow for safer titration of hyperventilation, as it may detect cerebral hypoxia. While craniectomy, either unilateral or bilateral, is a very effective way to lower ICP, its use is controversial due to its unclear impact on outcome. While multiple small studies have examined the efficacy of craniectomy, our current understanding is informed by two relatively large prospective randomized controlled trials, DECRA and Rescue ICP. In the DECRA trial, 155 patients with severe diffuse non-penetrating TBI and refractory intracranial hypertension were assigned to bifrontal temporoparietal decompressive craniectomy with sternotomy or standard care within 72 hours of injury. Despite a significantly lower mean ICP in the craniectomy group, mortality was similar in the two groups, and 6-month functional outcome was worse in the craniectomy group. There were major criticisms of this study, and they included pupillary reactivity at baseline. However, a post hoc analysis that adjusted for pupil reactivity found no difference in functional outcome. The study was also criticized for restrictive inclusion criteria, as only diffuse TBI patients were included, a controversial definition of refractory intracranial hypertension, which was ICP greater than 20 for more than 15 minutes, and use of craniectomy early during therapy, which was felt to be inconsistent with clinical practice, as well as the use of bifrontal craniectomy only. These study design issues were absent in the subsequent Rescue ICP trial. The Rescue ICP trial was an international multicenter parallel group superiority trial of 408 patients that examined the effectiveness of craniectomy, either bifrontal or unilateral, as last-tier therapy in patients with blunt TBI and refractory hypertension. Refractory hypertension in this study was defined as an ICP of greater than 25, lasting for 1 to 12 hours despite medical management. The pre-specified primary outcome was the 6-month functional outcome as rated via the extended Glasgow outcome scale. The authors plan to analyze the GOSI with an ordinal method based on proportional odds model. However, when the data were analyzed, the proportional odds assumption was rejected, and therefore the results were analyzed descriptively. Craniectomy was associated with a 22% reduction in mortality, which translated into a larger percentage of patients with a vegetative state and lower severe disability, as well as higher proportion of patients with upper severe disability. There were no differences in rates of moderate disability and good recovery. Therefore, it's not clear how to apply the results of this study in clinical practice, since the trialists could not analyze their data according to the original plan, and the primary outcome was negative. Regarding metabolic therapy, the goal of metabolic therapy is to suppress cerebral metabolic rate. If you reduce the metabolic rate, there's a reduction of cerebral blood flow, which lowers the cerebral blood volume and thus ICP. Furthermore, if you reduce CMRO2 in the face of decreased fuel delivery, it might preserve brain tissue. Reduction of CMRO2 can be accomplished by induction of pharmacological coma or hypothermia. In clinical practice, multiple sedative infusions are used, including opiates, benzodiazepines, propofol, and more recently, ketamine and dexmedetomidine. Currently, no single agent for continuous sedation has been shown to impact long-term neurological outcomes or mortality, as concluded by a 2011 systematic review. Based on this review, the Brain Trauma Foundation guidelines recommend that propofol may be used for ICP control, but not to improve outcomes. Induction of a pharmacological coma is a useful maneuver in the clinician's armamentarium. However, it should not be used prophylactically, but may be considered as a late-tier therapy to lower ICP. Propofol and high-dose barbiturates are recommended for treatment of intracranial hypertension in both the Brain Trauma Foundation and ENLS guidelines, although other agents are used in clinical practice. When pharmacological coma is employed, the agent should be titrated to an ICP of less than 20, an isoelectric EEG, or a deleterious side effects, whichever occur first. For an in-depth review, please refer to the On Call chapter entitled Sedation and Analgesia in Neurocritical Care. We'll spend a little bit more time talking about hypothermia, which likely has no role in the management of TBI. Numerous studies have addressed the role of mild to moderate hypothermia in TBI, both as a prophylactic strategy as well as a strategy to manage intracranial hypertension. And although these single-center studies were associated with improved outcome, two large randomized multicenter studies in adults with severe TBI, the NABISH 1 and 2, failed to show benefit of prophylactic hypothermia. A randomized study of hypothermia to treat intracranial hypertension in children with TBI suggested harm. The prophylactic hypothermia trial to lessen traumatic brain injury clinical randomized trial, the POLAR RCT, was an international multicenter trial published last year that randomized 511 patients with severe TBI to assess the effects of prophylactic hypothermia on functional outcome. The study found that early initiation of hypothermia neither improved neurologic outcome at 6 months nor controlled ICP better than normothermia. There was a higher incidence of pneumonia in both the per protocol and as treated prophylactic hypothermia groups. It should be noted that 27% of patients in the hypothermia arm never reached goal target temperature, but at present, prophylactic hypothermia should be avoided in patients with TBI. And perhaps as a last resort, decompressive laparotomy may be considered to treat refractory intracranial hypertension. Both intra-abdominal and intrathoracic hypertension may contribute to raised intracranial pressure, presumably through transmission of pressure from those cavities to the spinal subarachnoid space through the vertebral veins. In a series of 17 patients with refractory intracranial hypertension and intra-abdominal hypertension, but without abdominal compartment syndrome, Joseph reported a fall in ICP in all patients after laparotomy. Of these, 11 patients maintained a lower ICP and survived. But further study is needed to define the optimal role of laparotomy and its impact on functional outcome. As we discussed previously, if cerebral pressure autoregulation is disturbed after TBI, then CPP may affect CBF. Therefore, an attempt is made to target CPP within a range that minimizes cerebral ischemia. It's common practice to maintain CPP greater than 60, although this may not be optimal in all patients. The Brain Trauma Foundation currently recommends maintaining CPP between 60 and 70. Elevating CPP above 70 with IV fluids and vasopressors should be avoided because of the risk of lung injury. It should be noted that although CPP is an integral physiologic parameter in modern ICU care of the TBI patient, there is considerable variability on how it's derived. A survey study suggests that placement of the arterial line transducer, from which the map is derived, varies both across institutions and among the 11 studies cited by the Brain Trauma Foundation for their CPP recommendation. While some zero the transducer at the level of the heart or the phlebistatic axis, others zero it at the head. Now, if the patient is flat, there's no difference. However, when the head of the bed is upright, as it often is in patients with TBI, MAP measured at the right atrium is higher than that measured at the level of the tragus. Therefore, transducing blood pressure with an arterial line zeroed at the phlebistatic axis will result in an overestimate of the actual CPP. This is particularly problematic in patients who are treated with the head of bed greater than 30 degrees for ICP control, as the discrepancy between CPP measured at the phlebistatic axis versus the tragus could be as high as 20 millimeters of mercury. The lack of uniformity in clinical practice and in the published literature is problematic and potentially clinically significant. Seizures occur in 10 to 30% of patients with the TBI. The Brain Trauma Foundation guidelines recommend the use of an anticonvulsant for 1 week following TBI and recommend against longer durations of prophylactic therapy. Many centers use alternative agents such as fosphenytoin or levetiracetam. While not addressed in the current guidelines, paroxysmal sympathetic hyperactivity occurs frequently in patients with TBI and poses therapeutic challenges. PSH is a syndrome consisting of paroxysmal concurrent increases in sympathetic and motor activity. While not unique to patients with TBI, almost 80% of reported cases in the literature occur in patients with TBI. Refer to the On Call chapter for the Brain Trauma Foundation guideline recommendations addressing infection prophylaxis, DVT prophylaxis, nutrition, and steroid administration. And please see the PONS presentations on paroxysmal sympathetic hyperactivity, venous thromboembolism prophylaxis, and antithrombotic reversal in patients with intracranial hemorrhage for an in-depth review of these topics. While data are currently insufficient to define the optimal role of advanced neuromonitoring tools, the Brain Trauma Foundation guidelines specifically address brain oxygenation and offer recommendations for the use of jugular venous oxygenation and brain tissue oxygen monitoring to reduce mortality and improve outcome. It's increasingly recognized that the traditional goals of cerebral resuscitation, such as ICP, CPP, and other in the clinical exam, are distant surrogates for cerebral tissue perfusion that do not account for dynamic changes in autoregulation, tissue metabolic rate, cellular fuel utilization, and microcirculatory dysfunction, all of which impact tissue metabolic health. The emergence of technology that allows for continuous, real-time bedside monitoring of cerebral physiology might facilitate assessment of therapeutic efficacy and provide more relevant physiologic endpoints for resuscitation. Combining these monitors in a multimodal approach may allow goal-directed cerebral resuscitation that emphasizes the individual patient's unique neurologic and systemic physiology. This approach must ultimately be compared to algorithms that target more traditional physiological variables. A phase 2 study, BOOST 2, demonstrated that a management strategy that incorporated PbTO2 was associated with less brain tissue hypoxia and a trend toward improved mortality. A follow-up phase 3 study to assess the impact of this strategy on outcome is now planned. Currently available advanced monitoring tools for assessment of brain temperature, regional blood flow, regional oxygen saturation, cerebral biochemistry, which include lactate, pyruvate, glucose, glutamate, and glycerol, are all available. Relationships between these physiological variables may also be monitored. For example, a moving correlation between ICP and MAP, called PRX, may be determined, and given specific assumptions, may reflect cerebral autoregulation status. While the American College of Surgeons recommends assessment of cerebral autoregulation, this is problematic, as the techniques for doing so are not widely available. They also rely heavily on assumptions that are difficult to verify and are not supported by high-quality clinical data. Outcomes from TBI span the spectrum from death and to full recovery. While many factors predict poor outcome in large populations, these factors should not necessarily be used for prognostication in individual patients. The IMPACT, or International Mission on Prognosis and Analysis of Clinical Trials, and the CRASH, corticosteroid randomization after significant head injury, scores are externally validated models derived from large data sets. They can aid in prediction of 6-month outcome after TBI. However, it should be noted that functional recovery may continue for up to 18 months following severe injury, and these scores are of minimal utility for predicting ultimate individual patient outcomes. For more information on clinical and radiographic scores developed to assist with severe TBI outcome prognostication, please refer to the Severe TBI section of the Neurocritical Care Live chapter entitled Prognostic Assessment in Neurocritical Care. To date, unfortunately, no medications have proven useful in improving outcome after TBI. There have been over 200 failed neuroprotective drugs. 3 notable drugs showing failure to improve outcomes through randomized controlled trials in large cohorts of patients with TBI include corticosteroids and, most recently, erythropoietin and progesterone. The negative findings of these studies, despite excellent theoretical basis, positive preclinical trial data, and large sample sizes, led to calls by many researchers to reevaluate research methodology in TBI to better understand injury phenotypes and pathoanatomical groups so that we can guide research of this heterogeneous disease. It's unlikely that a single drug will prove efficacious, as the pathways involved in secondary injury are complex and redundant. Perhaps the best hope for neuroprotection lies in combination or bundles of therapy that target multiple pathways. Thank you for your attention. We hope that you come back for another installment of the Neurocritical Care On Call.